Hello, I'm Dr. Janice Reynolds Gibbs, Program Director for Henry Ford St. John Family Medicine Residency in Detroit. Welcome to our interview process. What we'd like to do now is take a few moments to just get a more in depth look at our program. As you may know, we are a well established program. We've been around since the early 1970s, and we have graduated hundreds of residents who have been successful in their careers, some of them who are still with us and have come back on as faculty or attending positions within our program. We are a fairly large hospital. Most of the training that you'll do will be at Henry Ford St. John, which is in Detroit on the east side of Detroit. And like I said, it's a fairly large hospital. We have over 700 beds. And that number does fluctuate from year to year, just depending on what we are doing in the hospital. We may be having more private rooms, installing different units. The hospital has gone through a transition over the years. I've actually been with St. John since I was a medical student in some capacity or another. So, as a medical student, as a third year, the newest part of the hospital, our North Tower, was not even there. It was actually a hole in the ground. And when I was doing overnight calls, there was all the banging that was waking me up as they were building those steel rods to actually put up the tower. So I have seen St. John through a lot of different transition. I was there as a medical student. During my third and fourth year, I went away from residency, worked in somewhere else, and then came back as a faculty member here in 2012. So, like I said, fairly large hospital. We are a level one trauma center, which is the highest designation that you can get. So we're going to get all of the traumas, usually from the east side. So if there are accidents, shootings, stabbings, assaults, anything that you would go to the emergency department for, we're going to be seeing it at Henry Ford St. John. We also have a level three NICU within our children's hospital, and that is the highest designation again that you can get. So we're going to be seeing the sickest babies. We're probably not going to be sending them out unless there is really something big going on. And even in that case, we're probably not going to be sending them to anywhere locally. They're going to go out to some of the tertiary centers like University of Michigan or Cleveland Clinic, somewhere out of state. So we're well prepared to take care of very sick babies here at our hospital. As you're on the interview trail, you might hear some of the terms opposed versus unopposed. And when you're talking about are there other residencies in that hospital that the program is associated with, I am not a big fan of those terms of opposed versus unopposed. So I like thinking of, are you in a collaborative program versus more of an independent or quote unquote orphan program. So we are definitely a collaborative program. We have several other residencies and fellowships within the hospital. Some of those residencies, besides family medicine, we have internal medicine, we have pediatrics, we have OB, we have emergency medicine, surgery, pathology, and podiatry, and then we're building even more fellowships within our hospital. So definitely a collaborative program that we have, but a very collegial relationship the residents have with the other programs. So there may be some informal curbside consulting going on within the hospital, but there are also these relationships outside of the hospital where the residents are getting together, having dinner, having social outings, playing on sports teams together. So they really are a close knit bunch within the hospital, the different programs that are at St. John. Officially, we are affiliated with several different medical schools. One of those medical schools is Wayne State University School of Medicine here in Detroit. We are also affiliated with Central Michigan University, St. George's University in Grenada, and Michigan State University. Now, in terms of diversity, you will see a very diverse patient population here at St. John. And a lot of that really just hinges on the physical location of the hospital. So we like to call it the three corners, where we really have three different communities that are meeting at our hospital. And we're going to see about a third of our patient population coming from Harper Woods, which is more a blue collar type of community. So we're going to see a lot of our public servants, our police officers, our firefighters, EMTs may live in Harper Woods. And that's really where our parking lot faces. Our actual hospital has the Detroit zip code, and so you may see some of our community from the east side of Detroit, maybe more of an underserved, underinsured community that's going to be at the hospital. And then on the other side of our hospital, near our professional buildings and our cancer center, it's going to be Grosse Pointe, and that's more of a white collar community. Sometimes we think old money, Fortune 500 company CEOs, some athletes as well, who would be in that community. And all of those patients are going to be at St. John. So you're really going to get a variety of patients that you're going to see. So with our training, like I said, most of the inpatient training is going to be done at St. John in Detroit, but we do have 2 outpatient offices. Our outpatient offices are located about 10 minutes or so, maybe 12 minutes, depending on how you drive from the hospital. Both of those offices are in St. Clair Shores, right outside of Detroit. The first one that we have is a family medical center, and then we have also our Masonic Medical Center. So we have residents at both of those locations. The family medical center is really the hub of the residency. That's where all of the interns are going to start. That's where my office is as a program director. Our residency coordinator, Liz, her office is there. The chief of the department, Dr. O'Byrne, also has an office at FMC, although she practices at our other office, and that's mostly for the department, not necessarily for the residency. We have a variety of faculty here, and then we have 2 of our private practice physicians who are actually practicing within our residency program walls, and so they have their own practice, and then they help out with precepting as well. So most of the residents, like I said, will be at the Family Medical Center. And then we have our Masonic Medical Center, which is really more of a attending run practice with a few residents sprinkled in. We're still seeing the same patient population that we're seeing at St. John. We're seeing the same population at FMC that we're going to be seeing at our Masonic Medical Center. But we just have 2 different offices for a little bit of a different experience. So same patients, same type of procedures, but the flow may be a little bit different. And like I said, at Masonic, it's mostly attendings with a few residents sprinkled in. Now, with family medicine programs, the last 2 years have to be done at the same continuity clinic. So you wouldn't be swapping between our family medical center and our Masonic Medical Center. So all of our interns are going to start at the Family Medical Center. They will have some experience at the Masonic Medical Center to see if they find that that's a better fit for them, whether that's location or they just like how things flow there a little bit. And so we do give them that chance to kind of put some feelers out there and see if Masonic is a good fit for them. During the springtime of the intern year, we take a poll of who might want to go to Masonic, and the number of people that go to Masonic really depends on what are the patient numbers there, what is the need for physicians versus patients. And so it may be 2 residents, it may be 3 residents, and we usually try to alternate that just to make sure that everyone is going to be having a good experience at their location. So in the spring, choose where you want to go. We never force anybody to go to Masonic. We want to make sure everyone is going to be successful wherever they go. You might have to be a little bit more of an independent worker at Masonic, but if that's where you want to go, we'd definitely support that if we think that a resident is going to be successful there. But we do give that option of Family Medical Center versus the Masonic Medical Center. Now, let's delve a little bit into the structure of our program, how we set up our 3 years, our curriculum. So, starting with the first year is going to be mostly inpatient. And again, that's going to be at Henry Ford St. John. That's where most of the rotations are going to be done. The first month in July, you're not going to just hit the ground running. We're not going to put you in the hospital or on different rotations, different services. The first month is going to be an orientation month. And we do that for a couple different reasons. We understand that we have learners that are coming from all different schools, all different backgrounds. We're trying to get you a little bit more on the same level. So we know you've had different experiences. So we want to make sure that everybody is kind of equaled out a little bit. So we're going to make sure that we're doing our certifications like ACLS, NALS, PALS, also the Advanced Life Support and Obstetrics courses. So we'll be doing things like that. We'll be making sure that people are up to date on how to do certain procedures that you're going to see more likely during that first year that you may have not done in medical school. We also want you to make sure that you are really familiar with the electronic medical record that we'll be using in both the office and the hospital. So you're getting training with that, learning who the people are that you're going to be working with for 3 years, whether that's your coworkers, your co-residents that you're going to be in the trenches with. Both the interns and the second and third years, the faculty, the staff at our offices. So getting to know those people a little bit better and what their roles are in the office and the hospital. We also do a couple other things with scholarly activity. So we do expect that you're going to do some kind of small research project. It doesn't have to be anything feasible, but scholarly activity is something that's mandatory for our program. And something that we are expecting all of our residents to do before graduation. So during the orientation month, we'll have our residents come up with a clinical question and then see, can you do a literature search? Can you come up with some of the background that you might want to pursue scholarship or scholarly activity in? And so, like I said, it does not have to be anything that's really feasible. We're just trying to get you to get your thoughts flowing about something that you might want to do and come up with a question and do a little bit of background on it during that orientation month. Definitely not a time to do a full project, but just to sometimes get a little bit of interest going in that area. Now, we work very hard during the orientation month, doing lots of different workings, lots of different projects that we have going on, going out into the community, but it's also a time to, like I said, bond with your co-residents and with the faculty and staff. So we do have a retreat, an all residency wide retreat that we're going to hopefully go out and do something fun. And really get to know people better so people are more comfortable as they start off in residency. So that's going to be the first month in July. When you get to August, then that's when things get a little bit more spread out. So in general, we have 2 months of our family medicine service. So when we say our family medicine service, this is a service that only has patients from either our family medical center or our Masonic Medical Center, our 2 outpatient offices. So we're not going to be fighting for patients with internal medicine or any other service. We will be seeing adults on our service. We may be seeing kids on our service. We also have pregnant women on our service. So really that family medicine, that full womb to tomb experience with our family medicine inpatient service. The inpatient service is usually made up of a senior who is our lead. That's usually a third year, maybe a late second year. Possibly 2 second years, 1 to 2 first years interns from our service. We may have a sub-I and we may have a visiting resident from another program, in which can include another family medicine program or one of our podiatry colleagues. So we have a variety of people on the service. And the way that we do our family medicine service is that we're not constantly doing walk rounds. Our residents are a little bit more independent. They're going to be seeing their patients on their own or with their seniors. And then we will be doing table rounds discussing what has been found so far, discussing the care and the plan. Now, 1 or 2 times a week, we would like to do walk rounds, and during that time, we're going to be doing some evaluation of our residents. Our residents, how are they doing with communicating with the patient? Are we doing appropriate physical exams? So we'll go around and do what we call a mini CACs, and the resident will see the patient for the first time, like we were not there, although the whole team will be sitting there watching, and we will then debrief in the hallway as the team goes a little bit further, the attending and that particular resident will debrief about the interaction. How did things go? What went well? What can be improved for next time? And then that's how we do some real-time feedback during that time. So again, that's 2 months of the intern year is going to be on our family medicine inpatient service. Now, we do work with our internal medicine colleagues several months out of the year. We have a full month of the medical ICU, so our MICU, MICU, will be on there. And then we also have our cardiovascular ICU. Now, we have made some changes where we cut down our cardiovascular ICU, which used to be a month-long rotation. We've cut that down to a 2-week experience because the feedback from our residents is 2 weeks was more than enough, and most of the residents are not going to be working in a cardiovascular ICU after they graduate. So what we did was pare that down to a 2-week experience, and then the other 2 weeks is our selective, where they can pick something that they want to do, or be assigned to be in geriatrics or doing some prenatal care with our OB colleagues. The other part of that selective is more outpatient care. So that gives you a little bit more time to build your continuity patient panel and see patients in the outpatient arena, which you don't have a lot of time for during the first year because everything is so inpatient based. We do have a month of orthopedics. That is the only month that is like purely outpatient. And why we do that during the first year is because we tend to do a lot of joint injections during our program, and a lot of that can happen during first year. So we want to make sure that you're comfortable doing those knee injections, those shoulders, maybe a hip or a wrist. And that is a good experience that our interns are getting during that first year. Now, we do work closely with our pediatric colleagues. We have several rotations with our pediatric friends over there at our children's hospital, which is housed within St. John. So we do a full month of inpatient pediatrics, a full month of outpatient pediatrics, and then again we pared down our ICU, our neonatal ICU rotation to 2 weeks because again our residents and our graduates gave us feedback that they're probably not going to be working in the ICU, neonatal ICU, so we didn't need a full month of experience with that. So we definitely take the feedback that we get from our residents seriously, and we take that under advisement. And that was one of the changes that we've made some years back. So 2 weeks of the NICU and then 2 weeks of the selective, where again, interns can choose something that they want to do, get more outpatient experience, geriatrics, or prenatal care. We do have a full month of adult ER during the first year. And again, that's our level 1 trauma center that you're going to be working with our emergency medicine colleagues at. And then we have OB days and OB nights. So we tend to do those back to back, and there's a method to that madness because OB is probably one of the highest risk things that our residents are involved in. And so it is also one of those things where you really have to get your feet wet, get to know the labor and delivery floor, the people that are working there, the nurses, the other residents and attendings, and the OB department. And that can take 3 to 4 weeks to do. So once you've had that 3 to 4 weeks, you don't want to go to another rotation and then have to come back and rebuild that rapport. So we do our OB days first, and then turn right around to OB nights, where you tend to be a little bit more independent and get more deliveries. So as I said, the first year is more inpatient based. You're going to do about 40 calls, and that can be when we're talking about OB calls or calls on your outside rotations. About 52 or so long calls. So you're staying later on our family medicine inpatient service. You may not stay overnight, but you're going to be staying later waiting for that night call person to come in. In terms of clinic, our first years are going to be seeing patients usually once a week, maybe twice a week, depending on if they're on the selective or orthopedics, depending on how that goes. We start off with the first 6 months of seeing 1 patient per hour for our residents, and the attendings going in on every encounter. And then in January of the intern year, then we're going to be scaling back to 1 patient every 30 minutes, and then plus or minus if the attending has to come in on those encounters. So that would be our first year. The second year is a nice blend between inpatient and outpatient. So it's a little bit of a breather. You will get more time with our family medicine inpatient service. So we have 4 months dedicated to the family medicine inpatient service. And one of those months is going to be an entire month of nights where you're just on call during the nighttime, taking care of the service, seeing admissions, consults, anything that may come in overnight. So really good experience there. The next rotation that we have during our second year is going to be our behavioral health month. This was previously psychiatry, where we're doing a lot more of inpatient psychiatry, and we found that really what our residents have been needing, have been wanting, what they're seeing in the office is more coming from a behavioral health aspect. So our residents will be working with our PhD behavioralists that we have here on faculty and doing some short-term interventions with our patients. So maybe somebody wants to work on weight loss, maybe they want to work on drinking less or medication adherence, things like that. We're going to be working on anxiety, depression, and just some short term interventions and motivational interviewing. So, our residents will be working with our PhD behavioralists during that time, seeing patients again that are only in our 2 offices. And so they can hopefully take the information and the training that they have gotten during that month and translating that into what they're seeing in the office and using those skills with their own continuity patients. Um, during the second year, this is a time that we have our residents have a more rural experience. We have them seeing patients with some attendings at River District Hospital, which is in East China. Before I came here as faculty, I did not know we had an East China in Michigan, but we absolutely do. So it's like a straight shot up I-94. So it's not too far away, but far enough away where they don't have all of the services that we have at St. John. So it's really, if you go to the emergency department at that hospital, and you have to get admitted, you're either going to get admitted to surgery or you're going to get admitted to medicine. There's really no other services there. I think they still have 2 OB beds, but they don't do any deliveries, unless it's something just very, very urgent that's there. But those are just the 2 services that are available. And our residents are working one-on-one with the attendings there. So we do send them out there to do surgery, and then we also have what we call a rural orientation as well. So the rural orientation is working more one-on-one with one of the attendings out there, and then of course surgery. We could easily do surgery here at St. John, but when we think about all of the learners that we have at St. John, you have your attendings, then you have your surgical fellows, then you got your residents, and then medical students as well. So I'm sure you guys have done enough of being human retractors on your surgical rotation in medical school. What we want to do is really have our residents have the experience of what are the risks of the surgeries that we're going to be doing, what are the complications, managing these patients post-op, because these are the patients that we're going to see in the hospital and in our office. So we want to make it more of a real life experience and something that's going to be useful for the future. So that's why we do our surgery out at River District and not at St. John. Another rotation that we're going to be doing is GYN, and of course that's with our GYN colleagues. Outpatient rotation, more pelvic exams, vaginal exams, maybe some procedures as well, things that we are also doing in our office, but maybe you don't have as many of those, just depending on how your clinic goes. So that's a good time to have experience with that. We also have a pediatric emergency medicine rotation. Now, if you remember your first year, you're going to be doing adult emergency medicine, and then the second year, you're going to be doing pediatric emergency medicine. We have a cardiology outpatient elective that is also part of our curriculum. So really working on EKGs and those things that you may see in our office and working one-on-one with our cardiologists. So that is going to be during the second year. And then we offer 2 months of electives. And so this is a time where if you're interested in something or you're not feeling quite comfortable with something, that you can really get more experience with that. So we have people doing nephrology, podiatry, endocrinology, some sports medicine things. So a variety of things. And we really do support our residents in doing whatever they want to do for their own education. Now, during the second year, I think it's about 80 calls or so. Half of those calls are going to be during that month and night, so you can just get those out of the way. And then half of the calls, again, are going to be those long calls where you're not staying overnight, but you may stay later until the night person comes, or during the day on a weekend until the night person comes. So there is more of an outpatient experience during the second year. So 2 to 4 half days of clinic, depending on what rotation you're on. Obviously, less if you're going to be on an inpatient rotation, more if you're on an outpatient rotation. And during this time, the residents are going to be seeing patients every either 20 or 40 minutes. So 20 minutes for a standard visit, 40 minutes for something that's either a procedure, a well adult, well child visit, things like that. So that is our second year. And then our third year, people really love because it's mostly outpatient. It's really what you're probably going to end up doing as family medicine, and then really just honing in all the skills that you've learned for the previous 2 years, and building up your continuity practice. So the first one that we have during the third year on our list here is going to be our family medicine lead. So the first 2 years, you're as a family medicine resident, you're going to be seeing the patients, writing the notes, and things like that. As the lead, it really is a different type of role, and so you're really overseeing your first years, your second years, your students, answering the phone for consultants who may be calling. Taking in information about new admissions or consults that come. So it's more of a leadership position. It's not necessarily seeing all the patients writing the notes, but making sure that the junior residents, the interns, and the med students are doing what they're supposed to be doing, and pulling all of that together. So it's definitely a different kind of experience and can be a different kind of challenge for our residents. We do have a half month of nights, and that again came from feedback from our residents that they didn't want to do so much more call during different parts of the curriculum, and so they would rather just do 2 weeks of nights here, get it over with. And that's what we listen to, and that's why we have the 2 weeks of nights there. And then we have a lot of outpatients. So we do another month of orthopedics because musculoskeletal is a big thing, not only on our exams, but what we see in real life practice. So we're doing another month of ortho. We have a month of dermatology. We have a month of community medicine, doing a variety of things, really getting to know the services that are available in the area for our patients. We do some hematology, oncology, ENT, ophthalmology, urology, and practice management as well, wound care, and then we offer a variety of electives. So we get like 4 months of electives during the third year. So again, residents can use that time for whatever they want. Some of the more popular electives during the third year are things like Mackinac Island. So Mackinac Island is an island here in Michigan, about 4 hours away from us. So you got to drive there, and then there are no cars allowed on the island. So you park and you need to take a ferry over, and people are walking or biking on the island, and you're there to be the island dock. So the permanent island dock is still there, but our residents are there being the island dock for that time. And really, it's a time to get to know, how much do you really know? So oftentimes you are not sure what you really learned, and you haven't been able to use those that training and those experiences, and this is a time to use those. So going to Mackinac Island can be one of those great electives. There's about a 2-year waiting list for that, so we usually ask during the first year if this is something that you might want to do. The time to tell us is then, and so we can get you on the waiting list and possibly get you there for the Mackinac Island rotation. Another opportunity that we offer is international rotation. One of our former faculty members goes to Kenya every year and has agreed to take and continue to take our residents. Now that he is retired from our program, our residents are able to go to Kenya, not for fun, but really for an intense clinical experience. Sometimes they're seeing 2,000 patients or so. When they go to Kenya, they're going usually in the fall of their third year to provide services to a community that doesn't see physicians or medical care on a regular basis. So they do go there during the fall, usually of the third year. And like I said, it's a pretty intense experience. For a couple of weeks, lots of patients, things that you may only read about, you actually see there. May deliver a baby or so. That's happened in the past, but an overall very fulfilling experience that our residents can get. So during the third year, like I said, it's mostly outpatients, so you may see your own patients in the office 4 to 5 half days per week. And at that time, we're still doing 20 and 40-minute appointments, and then 35 calls or so. And half of those are going to be on that month or that 2 weeks of nights, and then others kind of sprinkled in between. So we do have some longitudinal curriculum things. So like behavioral health, although we have a whole month, we're going to have behavioral health sprinkled into all 3 years. Our geriatrics program, and that will be with home visits as well as seeing your own patients in a nursing home. And then sports medicine curriculum, where we are the team docs for a local high school. So we're usually at all their football games. For another part of the community, we're going to be doing the sports medicine, the physicals that they need to be doing before they're participating in athletics. So we'll be doing that, and we do that in conjunction with some of our sports medicine colleagues as well as the physical therapists through the hospital. So a variety of experiences through the 3 years here at St. John. Now, in terms of didactics, we do have dedicated teaching time. So our second and fourth Tuesdays, we are meeting at the hospital. That is time where our residents are not scheduled for clinic. They shouldn't be scheduled for anything else. The only caveat to that would maybe be if you're on an ICU rotation or you're on nights or vacation, anything else. Otherwise, we expect you to be at the Tuesday afternoon lectures, because we really kind of carved that time out for our resident learning. So during that time, we usually have things broken up by system. So we may be doing cardiology, we may be doing endocrinology, women's health, things like that. And they're more resident run. So really finding different articles that may be of interest, doing a journal club, we may be doing M&M. That is also a time for us to use our sim lab and to do procedures and attendings to go over some of those things and questions as well. So that's our second and fourth Tuesday. And the reason why we do second and fourth Tuesdays is that previously we were doing Tuesday, Wednesday, and Friday mornings at 7:30 in the morning at the hospital in person. And as you can imagine, that can be quite challenging for both residents and faculty members to get there that early, 3 times a week, and then rushing off to clinic. So we decided to carve out some time that was later on in the day for all of our residents and our faculty to be there for our dedicated teaching time. Now we do still have our Friday morning, 7:30 a.m. Lecture time. We try to do most of that virtually. These are more CME polished presentations, either by our family medicine faculty or another attending in an outside program. So again, those are usually virtual. We do say the fourth and fifth Friday to be in person, so that we can do some more bonding, to do some more inpatient or in-person lectures. We do in-training exam and board prep during that time, and also some wellness time during those fourth and fifth Friday lectures. So we like having that in person and virtual. In person because that's a time where we've been spread out all over the hospital and different areas. Some people are in clinics, some people are in cardiology, some people are in emergency medicine, maybe at a different hospital, elective or what have you. And so they don't see each other on a regular basis. So when we come together on those Tuesdays and those fourth and fifth Fridays, then that's a time to really, see our fellow colleagues, get to know what's been going on since we haven't seen them, and it's a good bonding time during those times. So we've also implemented some other times where we have some more one-on-one education for our residents with our faculty. So we have started our class-based Tuesday afternoons. So these are going to be quarterly for our residents, and it's going to be the first year class, the second year class, the third year class, and we're going to be doing a specific procedures so that we can look at demonstrating competency. So we might be doing things like ultrasound. We might be doing things like IUD placements, joint injections, but we're really looking to demonstrate competency and to work with those residents one-on-one on things that they may be doing in the office or possibly the hospital. So that's our class-based Tuesday procedure afternoons. And then we have our procedure clinic at our offices where you're working one-on-one with one of our faculty members, and all we're doing is procedures. So we're not scheduling diabetes checks, hypertension. We're not going to be looking at Welch-House or Willowdells or anything like that. We're solely focused on doing procedures for our patients. So that is what we're going to be doing for our didactics and our extra teaching. Now, in terms of our faculty is made up of 10 board certified family physicians and 1 PhD behavioralist. So we're very fortunate to have both MD and DO faculty members. So we have our DO faculty who will be doing some osteopathic manipulation with our DO residents, and also teaching our MD residents as well, and really providing a great service for our patients. We do have 2 attendings, as I mentioned before, who are not core faculty members. They're not going to be doing a bunch of evaluations or rounding in the hospital, but they will be practicing within our office at the Family Medical Center and precepting weekly. And so we have those 2 attendings there. And our faculty and our attendings really are making up the breadth of family medicine. So we all have our different niches. We have people who are interested in do OB, some women's health, pediatrics, geriatrics. One of our faculty is fellowship trained in geriatrics, procedures, ultrasound, behavioral medicine, community medicine, wellness, practice management. So all the things that are going to be making up family medicine, and how you're going to practice as an attending physician. We have each of those things in our faculty, because everyone is interested in a variety of different areas. About our grads, our graduates are going to be doing a variety of things. Most of them are going to be doing outpatient medicine. That's primarily what family physicians are doing. We do have some that are doing more of the traditional inpatient and outpatient, and there are a select few who are just straight hospitalists doing hospital medicine. Locum tenens is also something that some of our graduates have done. And then we've had a fair number who have done fellowships. Now, the most popular fellowships are kind of ranging between geriatrics and sports medicine. We've also had people do hospitalist medicine, women's health, and OB as well from our program. So really a variety of locations, a variety of different type of practices that our graduates are doing, and they will all tell you that they felt well prepared after leaving our program. So overall, the training at Henry Ford St. John will offer a diverse patient population for you, a variety of pathology, excellent teaching, and really the ability to go anywhere and everywhere after you leave us. So I hope this video was informative. Get to know a little bit more about our program. And I thank you very much for your consideration of Henry Ford St. John Family Medicine Residency. Thank you.